To determine the length of the catheter needed for your patient, estimate the distance between the insertion point of the catheter and the right atrium. This can be done by measuring a line from the mid portion of the neck, which is halfway between the ramus of the mandible and the thoracic inlet. Extend from that point to the sixth intercostal space. Choose a catheter that is close to this length. Final catheter placement should be adjusted and confirmed with fluoroscopy during the catheter placement procedure. It is optimal for the tip of the catheter to be placed within the right atrium. However, catheters can also perform quite well if the tip is located within a few centimeters in the cranial or caudal vena cava. This is a demonstrational video on the placement of a hemodialysis catheter in a dog with a percutaneous modified Seldinger technique. We will be placing an 11.5 French by 20 centimeter long temporary silicone catheter in the right jugular vein. This catheter is being placed in a clean operating room with fluoroscopic guidance. All operators are gowned and are wearing full barriers, including mask, cap, and sterile gloves. The dog is intubated and being maintained under general anesthesia. Wide margins on the right and left sides of the neck are clipped and aseptically prepared. Clipping both sides is ideal to allow for a change in patient positioning in the event that the right jugular vein cannot be catheterized. An esophagostomy feeding tube will also be placed following catheter placement. Some people prefer to drape the surgical field from the beginning. However, my preferred technique is to place the drape after the initial percutaneous catheter has been placed. This allows for a wider field of view, which can be particularly helpful if the jugular vein has been used for recent venipuncture or if the patient is overhydrated. When placing a catheter using this technique, the operator will either double glove and discard the outer pair after the percutaneous catheter has been placed, or they will swap gloves for a new pair. This is because the operator will inevitably make contact with the fur of the patient during initial catheter placement. It is helpful to place rolled towels under the neck to help extend the head away from the shoulder, providing a larger field of view. After the jugular vein has been identified, a skin nick is made using a number 11 scalpel blade over the intended location of the catheter placement. Be sure to tent the skin to avoid puncturing the vessel, and be sure that the skin incision extends full thickness. An 18-gauge over-the-needle catheter is used to obtain initial vascular access. Some operators prefer to hold off the jugular vein themselves, while others prefer to have an assistant perform this task. Once the catheter has been inserted into the vessel, a flash of blood will be observed in the catheter hub. Advance the catheter slightly, then advance the catheter over the stylet. When the catheter has been completely inserted into the vein, the stylet can be removed and the cap can be moved from stylet to catheter to prevent further blood loss. At this time, the operator will remove their outer gloves or change to a new sterile pair. If not already placed, a sterile drape can now be placed around the peripheral catheter. Be sure to use a long enough drape to prevent the long guide wires from becoming contaminated. When multiple assistants are involved to help hold the guide wire, a smaller drape may be used than when placing the catheter alone. At this time, the C-arm would be moved into position and collimated so the chest is in view. Be careful not to include the neck, which could result in exposure to the operator's hands. After alerting the anesthesia team that a guide wire is being placed, the operator will begin to pass the guide wire through the peripheral catheter. Straighten the J-turn of the spring wire and gently start advancing it through the peripheral catheter. Guide wire advancement should be smooth, however some resistance may be met if the wire becomes held up by valves within the cranial vena cava. Fluoroscopy should be used to monitor guide wire placement. This allows for safe and proper placement of the wire and prevents inadvertent placement into unintended locations such as the azygous vein. Fluoroscopy also helps prevent the operator from causing damage to the vasculature from advancing the wire too forcefully. The wire will typically be placed through the right atrium and into the caudal vena cava. However, if the wire is not long enough, the tip of the wire should be within the right atrium. Now that the wire has been placed into the caudal vena cava, the peripheral catheter can be removed off the wire. It's very important that the wire be grasped at all times to prevent inadvertent loss of access. Also be sure to maintain the sterility of the guide wire. A dilator is now passed over the wire and into the jugular vein. The dilator will stretch the size of the opening made into the vessel. In this case, it will dilate an 18-gauge hole to an 11 French hole. This is a large step, so some resistance will be encountered. Make sure the dilator is lying flat, parallel with the vessel, rather than at a downward angle. When the tip of the dilator has passed through the skin, hemorrhage will typically cease. Grasp the dilator a few centimeters from the skin and begin to advance into the vessel. Counter resistance can be created by pinching the skin deeply to help stabilize the vessel so that it doesn't push away as the dilator is advanced. If there is significant drag by the skin, you may need to extend the initial skin nick incision. The dilator does not need to be completely inserted into the vessel. Its job is to dilate the opening. However, this can be helpful if dilation of the jugular vein is also needed. The dilator can now be removed over the wire. Be sure not to withdraw the wire at the same time. Fluoroscopy can be used to verify that the wire is still in the intended location. Some catheters may require a second or third dilation prior to catheter placement. If so, be sure to start with the smallest dilator and move serially with subsequent dilations. When the dilator is removed, there is now a much larger opening to the vessel, so hemorrhage is expected. An assistant can use sterile gauze to apply pressure to the jugular vein while grasping the guide wire. After the final dilation has been performed, the catheter can be advanced over the wire. Be sure to flush both lumens prior to catheter placement. The proximal lumen should be clamped. Depending on the catheter being used, the distal lumen may also be clamped at this time. The catheter being used in this patient has a stylet within the distal lumen that helps stiffen the catheter. This lumen should not be clamped with the stylet in place. The catheter is slowly and gently advanced over the guide wire until the tip of the catheter reaches the desired location. Fluoroscopy should be used to monitor the advancement of the catheter. Depending on the size of your patient and available catheters, the proper location of the tip of the catheter is the right atrium or the caudal vena cava. Here, fluoroscopy is used to confirm the tip of this catheter to be within the caudal vena cava. The location of the catheter should be recorded to allow for proper connection to the dialysis machine to avoid access recirculation. If the catheter is placed in the caudal vena cava, the distal lumen will be used as the arterial access, while the proximal lumen will be used for venous return. A syringe is used to test blood flow within the proximal lumen. Flow should be smooth and brisk. If there is resistance, or if the blood flow is interrupted, fluoroscopy should be used to investigate for incorrect placement or other causes of luminal obstruction. After testing blood flow, this lumen should be flushed with sterile saline to prevent intraluminal thrombosis. Finally, place a sterile injection cap over the end of the hub. The guide wire can now be removed from the distal lumen. Maintain the sterility of this wire in the event that the catheter needs to be moved to achieve more optimal blood flow. If present, the stylet can also be removed. Be sure to clamp the distal lumen after the stylet has been withdrawn. The distal lumen should be aspirated to test for ease of blood flow. If flow is not smooth, use fluoroscopy to evaluate for possible causes. After ensuring satisfactory blood flow, flush this lumen with saline and place a sterile injection cap. With the guide wire removed, the final location of the catheter should be recorded. Fluoroscopy allows for capturing of this location without the need to transport the patient to an X-ray suite. The catheter is secured to the skin using 2-aught nylon. A suture should be placed on one side of the house through the designated suture hole. Be sure not to hit the jugular vein or other structures while placing this suture. One suture tag should be left long from this knot. This is repeated on the other side of the house through the designated suture hole. Again, be sure to leave one suture tag long. With just these two sutures in place, if the catheter is pulled cranially, there will be separation from the skin and exposure of the catheter. This movement can lead to irritation and increased risk of exit site skin infection. Excessive catheter movement could also lead to malpositioning of the catheter, kinking near the skin, or even catheter removal. To help prevent this, an extra suture is placed. Pinch the skin over the catheter where it is traveling down into the jugular vein. Place a suture throw perpendicular to the direction of the catheter, approximately 3 to 4 millimeters from the skin edge. Be very careful not to make contact between the needle and the catheter or the vessel. If so, this could result in hemorrhage or trauma to the catheter itself. After tying 2 knots to secure the suture, tie 1 tag to the previously placed knot at the side of the catheter house. You will use the long tag you created previously to tie this new suture at the skin edge. This should lie flat, and be careful not to create too much tension. After placement of 5 or 6 throws, the ends of the suture can be cut short. This is repeated with the opposite side. With those sutures in place, you can now see that as the catheter is pulled cranially, the skin will travel with it, helping to prevent infection and damage to the catheter. At this point, the sterile drape can be removed. A figure-8 suture will be placed above the house to stabilize each catheter lumen. This helps maintaining proper position of the catheter and prevents kinking. Removing the drape allows this stabilization suture to be placed so that the catheter hubs will be in an accessible location and to avoid annoying the patient if placed too close to the side of the face. This is the final appearance of a properly placed and sutured hemodialysis catheter.